Great pleasure to be here. And I'll just go into the topic itself, surgical and prosthetic digital implant integration in the aesthetic zone. So, I'm a prosthodontist by nature. I've been placing implants since 1996. I've been restoring these implants. And during this time, over 27 years of placing and restoring implants, everything has evolved. Again, going into the subject itself, which Ahmed, Alan, Christian Kochman, the Anini brothers have been talking about, how to integrate nowadays surgically and prosthetically, whether manually or analog-wise or digitally. These are the cases, again, that unfortunately we still have in our private practices, whether referrals coming to us. And when you look at this, is this good integration between surgery and prosthetics? It's all, again, about three things. It's about prosthodontics, prosthetics, it's about biology, it's about hard and soft tissue. It's about proper positioning. As Ahmed was just saying right now, these are not complications, these are mistakes that are done by implant restorative dentists or implant surgeons. And when they're referred to us, now they're complications we have to deal with. Again, these are my cases. Over 24 years ago, when I started placing implants, 1996, 97 was the introduction of immediate extraction and placement of implants in sockets in the aesthetic zone. And I started doing that. As a prosthodontist who has been taught in the States, we were taught to place the implants in the center of the socket. No knowledge about hard, soft tissue, biology. It's just placing this piece of metal in the socket and restoring it. And when we look at it, look at the soft tissue. No analysis to the soft tissue itself. Nothing about the labial plate, how thin it is, where the gaps should be. All what has been said before, and you'll keep on seeing and hearing everybody talking about this part. We need to analyze, we need to plan properly. When we're going to place implants in the aesthetic zone, we need to analyze the soft tissue. Again, we're dealing with two types of biotypes, phenotypes, whatever you want to call them. Thin scalloped and thick flat soft tissue, with the contact points depending where the papilla is on the types of biotypes itself. Now, when we start integrating surgery with prosthetic, we have to use all the tools we can, specifically in the aesthetic zone, whether you're using microsurgery approach, a microsurgical approach, to the extent we need microprosthetic approach to design our prosthetics in the aesthetic zone itself. So this is my practice back in Cairo. I'm from Cairo, Egypt, by the way. This is my practice up here, and we have a branch in Lisbon with a friend of mine, Alejandro Vivas. So whether you're placing implants freehand or now digitally guided, it doesn't really matter. First, we need to understand the biology, the hard and soft tissue. We can build bone, we can reconstruct soft tissue, and we can have this result after 10 years, stable. But to do this, we have to integrate biology and prosthetics together. Again, everybody has been talking about it, the labial plate, the problem of immediate extraction. We're going to extract, you're going to lose the labial plate if you don't place anything inside. From the study that was done by Lindy and Nevins, once you extract, we know the full labial plate is lost if you don't place anything there. So when do you decide to immediately extract, place an implant? When do you decide to immediately extract, reconstruct, or just leave it to heal and then go in a delayed approach? So, just taking a look again, 1996, we used to extract, As you can see, remaining roots. Place the implant in, as we were taught, in the center or the middle of the socket itself. Look how thin the labial plate is. Placing these implants, at that time, Brannemark implants, external hex, that's how we were taught at that time. In the middle, placing just a piece of collagen membrane, and then this is how it ends. We extract, we place, and we have an integrated implant. This is an integrated implant. And nowadays, we don't open second stage. Imagine you're doing this and you don't open a second stage, what's going to happen? You're going to restore it, and after a few years, what's going to happen? Bone loss, recession, ailing and failing implants. So proper positioning is very, very important. Why do you think I lost the labial plate here? It's because of positioning. And sometimes, as much as you are experienced in placing implants, specifically when we're talking about immediate extraction sockets, immediacy, whether in single or multiple, sometimes you can't place the implant in the right position, and we end up with these mistakes and complications that you need to solve later on. Look at this. Junctional epithelium, we have what? Loss of the labial contour, soft tissue-wise. And we need at that point now to solve. So how do we prevent this? Is doing it the right way. Not to start again and try to solve these problems that we create, these mistakes that we create by ourselves. Again, as a prosthodontist, we focus on the design of the implant because, again, we're talking about immediacy, immediate extraction, immediate placement of implants in sockets. You need good primary stability. Raquel in the morning was talking about the protocols of proper primary stability for loading. So again, the design of the implant is very important. Again, from a photoelastic stress and strain analysis study that, if you see in textbooks 30 years ago, it was done, it shows the amount of stress and strain pattern around the head of the implant. Again, that's why the designs of the head of the implant is very important. Why? Because 60% of the stresses, occlusal stresses, are transmitted to this part. And what's this part? That's the subcritical area that we call, the supracrestal part, that all the complications occur. This interface is where the complication happens in aesthetic implant dentistry, nothing else. So that's why the design is very important for stability. These microchannels or microthread design in most of the implant companies to give a better surface area contact to bone, so it reduces the amount of stresses. Again, when we're dealing with extraction sockets, where do we place our implants? According to what? What do we do? What diameter do you use? And why should we use what type of diameter? The diameter depends on two factors. The gap size that you and I want to leave in front of the implants. It's not how you drill and you end up with. It's what amount of gap do you want to leave intentionally. And of course, the socket size that you're dealing with in a buccolingual dimension and in a mesiodistal dimension. Do we graft? Do we not graft? Ahmed has shown several publications by the Atlanta team, New York team, dual zone, veneering grafting, and then later on, of course, again, my dear friend Howie is going to be talking about the evolution of how to stabilize the labial plate using the socket shield technique. Look at the thickness of this labial plate. This is the most challenging and very critical part of implant dentistry in the aesthetic zone. This very thin labial plate, this bundle bone, which Ahmed was just talking right now, once you extract, all the blood supply from the periodontal ligaments that you removed has vanished. So definitely you've got to get bone resorption. Again, when we look at the angulations, the drilling, how we place implants, where should be the implant, where should we drill in the socket itself, and where do we end up with? Are we going to drill it like this in the palatal, exactly in the palatal? Freehand, do we need guides for this? Can you do it freehand? Experienced surgeons? What do we end up with? And that's the problem again. This is the whole issue. This part is the most critical part. That's why they call this area the supracrestal or subcritical area, that we have to understand, we have to design certain things in our prosthetics. And we know from the work of Joseph Kahn in 2011, 2012, the amount of remodeling that inevitably you're going to get regardless where you're going to place your implant and when you place your implant in the proper position, leaving the gap that you need, placing the bone material, the biological bone material, in this gap. Whatever you do, and loading it, good primary stability, you will still get some dimensional changes. And you will still get remodeling and bone loss. Where? At this same critical area, the implant abutment interface, where again all the complications, all the aesthetic problems start, and then you get these bone loss and recessions around. So, what is the gap size? The gap size, if we have labial remodeling around 1.2 to 1.5, you're going to lose bone. We have a very thin labial plate around 0.7 to 1 millimeter. We need to graft, so we need at least a 1.5 to 2 millimeters of gap in front of your implant plus your 1 millimeter of labial plate. So we're talking total around 3 millimeters of bone in front of it. What about the diameter in a buccolingual dimension? Because again, I was taught over 27 years ago, when you can fill the socket with an implant, it's much better. Larger diameter, less stress. Definitely not. So when we're dealing, for example, with an upper central, the maximum diameter is between 3.5 to 4 millimeters. Now, an article that Howie came up with from several years is, again, when you're dealing with immediate extractions and immediate implant placements, depending on the buccolingual dimension, depending on the buccal wall and the palatal wall itself, and how, where to exactly drill. You have different configurations in a buccolingual dimension. When you're taking cone beam CTs, you have to analyze this. We have different configurations. Look at this. You have maybe a thick labial plate and a thin palatal. Maybe you have a thin labial plate and very thick palatal bone. And that's where we want to hit and place our implant. So depending on the configuration in a buccolingual dimension, we start analyzing where to place the implant exactly. Like, look at these cases, some of my cases here. Look at the upper left, the upper right. We have very good triangular bone where we want to place the implant. You can gain good primary stability. You can restore it immediately, provisionalize these cases, putting in mind placing the implant in a proper angulation, proper inclination, leaving the gap, filling it with the biological material, and immediately provisionalizing it. Look at the lower cone beam CTs, like a case like this. This case was maybe 8 years ago. Look at the buccal wall, the labial plate. It's almost fused to the root. You can't see a labial plate, very thin. And a fractured root, would you choose to extract it? If you extract this, place an implant palatal, which you have a lot of bone, you're going to need bone grafting, soft tissue grafting. So maybe in this case, the best option is to leave the root. Remove the palatal part, which is socket shield. Again, and place your implant and immediately temporize it. What about this one? Look at the buccolingual dimension. Very thin labial, very thin palatal, some infection. We know we cannot extract and immediately place here. You need to reconstruct the bone, maybe the soft tissue. So this is the case I'm talking about. And it was my first socket shield case, but it was guided. I do a lot of guided cases, not every case, definitely. And I was honored to be speaking in Dental XP in Miami. And this was my first case of guided socket shield that I planned in the office, in-house, where to exactly drill through the root itself, remove the palatal part, and then drill through the bone to place the implant in the proper position and immediately provisionalize it. Digitally, milled, everything was planned, milled, the surgical guide, microsurgical approach. We don't open flaps, use the concept of microsurgery, placing the implant, getting good primary stability depending on the threads of the design of the threads of the implant itself. Now placing a scan body, scanning the implant. While the patient is sitting down, we're milling our tempori. And I like to mill a lot of temporis, not in acrylic, not in PMMA. I use Emax or full anatomical zirconium for the best quality of the soft tissue. It influences the soft tissue. Before and after, I had a 3-unit bridge with this fractured root in the middle, and this is after immediately. Another case. This patient comes, she's like 26 years, look at the fracture of the crown from the root, and the cone beam CT shows very thin labial plate almost fused to this fractured root, while we have good amount of bone palatal to the root. So the same thing. Here is the case. She came like this. She came with all these composites, all these class 3s. And look at the soft tissue. When we analyze the soft tissue, look at the papilla. This is a thin scallop. Look at where the contact points are. Look at the papilla itself. You want to preserve this. If you start to extract traumatically or atraumatically and you lose the labial plate, you're going to lose all this configuration. So we decided we're going to go for a socket shield. Again, I don't do a lot of socket shields, but it is a very valuable option, specifically in aesthetic cases with this type of phenotype of the soft tissue itself. Removing the palatal part, placing the implant in a proper position. This was not guided, freehand. Placing bone, but the primary stability, I wasn't comfortable about it. So what we did, we just took the crown that she had, and I just resin bonded it to the neighboring teeth. And here it is. And now, after 2 months of integration, now comes the digital part. Everything we scan, we do digitally. In this case, there's a tie base and a zirconium milled abutment that is going to be cemented on this or bonded on this tie base. And then we do another crown, which is full anatomical zirconium, on top of the milled abutment. And look at the soft tissue here. Look at the papilla. This is immediate temporization after a couple of months, you can see. And this is the full anatomical zirconium. And look where the levels of the venous is, the cervical. You've saved everything. You did not interrupt or disrupt the soft tissue. So this is how we started, this is how we ended. Again, the whole procedure. Now, every tool that you have, we need to integrate it surgically and prosthetically. This case, remember, look at the buccolingual dimension. Very thin labial plate, very thin palatal plate, infection at the apex of the root. What are you going to do here? Are you going to immediately extract, place an implant, bone, or would you rather do it a staged part in which you extract, place bone, maybe if you need soft tissue, and then at the end, look at the buccolingual dimension. Can you place an implant, putting in mind you want to leave this 2 millimeters in front of your implant, freehand, even experienced surgeons, sometimes we need guided. So in this case, after bone grafting, after 4 months, now I start planning my case according to where my prosthetic is going to be, my crown, where am I going to be placing my implant exactly, leaving around 2 millimeters in front of the implant with a surgical guide. So this is just the case extracting. You can see the fracture here, and you can see the lateral. She has some composites. At the end, she wanted to do some aesthetic work on the 4 anteriors, proper extraction, placement of just bone. And in this case, if you look at the soft tissue here, if you look at the soft tissue, she has very good amount of keratinized tissue in the labial aspect. Robust tissue, you don't need to do anything. You want to preserve this architecture. You don't want to open any flaps, nothing. You atraumatically extract, place your bone inside. And what I was doing here, I completely sealed this opening of the socket because you don't want any of the bone graft to come out. How do I do this? You can either take a free gingival graft, you can use a connective tissue graft. In this case, the patient didn't want, so we just used something called the dermal matrix. You've all heard about dermal matrix, which is a soft tissue allograft, in other words. And suturing it. Then, look at this after 4 months. First of all, again, look at the soft tissue. I preserved everything. She has very good amount of soft tissue, very good quality of soft tissue. What type? She's not thin scalloped. She's the type of thick and flat. Now, I have my bone inside after 4 months. Now I want to do everything digitally and guide it. So everything was planned. Now here, what do? Do I open a flap? No. My guide has been milled, CAD/CAM milled in office according to the plan, exactly where I want to place my implant in this buccolingual dimension, this limited buccolingual dimension. We open a small opening where I want through the guide, and then I guide my drills to place my implant. And sometimes, instead of removing the soft tissue, as you can see here, we just do a roll flap or a roll technique to give more thick tissues around the implant. These are the steps. And then again, after placing the implant, we scan the implant immediately, and then we mill. At that time, I milled it in PMMA. That was like 8 years ago or more. And we bonded it on the tie base. And then we immediately delivered screw retained. After another 3 months, looks horrible, but the soft tissue is there. Doesn't matter. You can take several steps. As a prosthodontist, I like to do sometimes several temporaries to develop and stabilize the soft tissue. Look at the amount of soft tissue here. Yes, doesn't look good as aesthetic, not the soft tissue, the teeth or the crowns, but look at the soft tissue. Now, we're changing this PMMA and the adjacent root canal tooth to an Emax temporary crowns for better soft tissue quality. Doesn't look that nice, but stay with me. 6 weeks after, look first of all at the papilla. Look after 6 weeks. This is the soft tissue. Look at the junctional epithelium. Look at this subcritical area. That's what I'm talking. This is called the subcritical area or the supracrestal area, which again, all the problems and complications occur. Now, what do I want to do? I want to capture this. I want to do the soft tissue scanning. I want everything digitally because, as Christian Koshman was talking, when you plan everything digitally, you can zoom, you can magnify on your computer. You can design this subcritical area that you want to do so it does not push or influence your soft tissue. So this is the part that you want to capture. Again, in the morning, and everybody was talking, our friend Ramon from Spain has this article in which he showed different zones of your subcritical area or supracrestal part of your implant, in which you have to design depending on the level of the platform of the implant where you've placed it, depending on the vertical height of the soft tissue above your implant. It depends on this distance, how you design this subcritical area in your prosthetic. And it's called the esthetic biological contour concept. Again, this is the part that I want to capture. Now I capture it digitally, and on my computer and software, I start designing depending on where this level of the soft tissue is above the head of the implant. And then from there, we mill the implant crown, which will be again on a tie base, while the remaining teeth, she had some veneers and crowns, did in the same visit while she's sitting in the office. It took like 2.5 hours immediately, and then she traveled next day. So after designing everything according to the subcritical part, now we mill it. This is the Emex try-in, and this is immediate delivery after maybe an hour of milling. Look at the soft tissue again. This is a root canal tooth. This is the implant. Look at the soft tissue quality around it. Look at the papilla. Because from the beginning again, she had very good amount of quality of soft tissue, and we did not disrupt or interrupt this area by extracting it or opening a flap or doing anything more than needed. This is the case from the beginning. That's after 8 years. So coming from a stage of this to this, you need to integrate surgery, prosthetic, every tool you have. What about, we were talking right now about single extraction, immediacy, when you have multiple, maybe two. So this case here, look at this patient. Quality of the soft tissue is okay. We take the cone beam CTs, look from this side. The cone beam CTs, very good vertical height of bone in this edentulous area, but look at the buccolingual dimension. Very thin, 3.15. So for sure, we're not going to be placing immediate implants here. We need to reconstruct this area. So I decided we're going to do the whole digital workflow for the bone grafting, harvesting, and the implant placement. So I decided I'm going to go for the Huri technique, which again, I learned from Howie, the master of Huri, the master of socket shield. And after I finish, you guys are going to get a treat at the end of this day. Designed everything where I'm going to take my piece of block, this autogenous piece of block from the external ramus. Designed exactly where I want, 3D printed this guide. 3D printed the area where I'm going to be placing this bone, the Huri, and where I'm going to be taking it. As you can see, this is a 3D printed guide. This case is now 5 years almost. Here's the surgery. Just a quick view about it. Opening, and then we place this 3D printed guide. Stabilize it, of course. You have to understand something. Any guide, whether it's for harvesting bone, for placement of implants, when it's too supported, the most accurate types of guides surgically are the two supported, and we're going to go into that in a few minutes. Using the piezo through this window, which was designed according to the size that I want from my CT on the software, that's where I take my block. Take the piece of block, you can see it's a cortical, cancellous from inside. Now I start to scrape just around these edges and then close this area, this harvesting area. Now I scrape the bone, as you all have seen before, and you're going to see. Scraping cortical bone, autogenous bone, gold standard, full of bone morphogenetic protein. And now we open the surgical site. Look at the thickness of this buccolingual dimension. At the central area, okay, we have like 3.15. At the lateral and then the canine, we have like 3.5. Now, splitting this piece of bone after scraping, now I have a thickness. I want to make it very thin. So splitting it, make it into size, and now we're going to fix it from a labial and a palatal aspect, and then take the autogenous bone that was scraped from this piece of bone and place it in between this gap. That's from the buccal, from the palatal. And then we place the autogenous bone. Just let me go a little bit faster. Place the autogenous bone, fully autogenous, which was scraped from the piece of bone that we took out from the external. And here I just place sometimes a membrane. You don't have to place a membrane. It just gives more protection to it. That's the procedure. There's the guide. We fix it on the teeth, the adjacent teeth, and distally we fix with a fixation screw to make sure while we're harvesting this piece of bone through the window, it doesn't move. And these are the screws. Here it is. That's the bone, cortical, cancellous. Scraping it, taking the autogenous, splitting into two pieces for the buccal and the palatal, fixation, placing this autogenous bone inside. And then suturing, healing after 10 days. After 4 months, you can see through the very thin mucosal tissue now these screws, they want to come out. They want to exfoliate. They want to come out. So the full digital workflow, I've done it, the bone I've already harvested digitally, guided. Now placing the implant is going to be guided. So I design now my guide according to the amount of bone that I have had after this grafting with the Khoury technique. And now accordingly, I choose the implant size, the diameter, the amount of bone I want to leave in front of the implant. This case was planned. I sent it to the CT planning software center that I use most of the time, owned by a dentist, understands implants very well. He was not there. He left it to one of his assistants, and they did the planning and the surgical guide. Remember the communication Christian was talking about? So what happened? He sent me a guide. Everything looks fine. And that's the virtual implant placement. Here's my guide. Do I open a flap now? We need to open a flap to remove the screws from the labial plates that we placed from the Khoury. There they are. There is the bone. Very good quality bone after 4 months. Placing our guides, drilling, placing my implants according to the guide. And then you look at this, look at the central, where it is. Remember, guided surgery is all about correlating the anatomy of the bone to the future position of your crown or teeth. Okay? So a very well-planned, well-prepared, and well-designed, and well-manufactured guide will allow you to optimally place your implant, and it actually allows you to see without looking. That's what guides do. But again, remember one thing. Guides. We guide the guides to guide us. Okay? So anything wrong from the planning, that's what you end up. Look at this. I have like what? 1 millimeter of bone at the central, and that's a guided. Can't do anything about it now. Placed it, sutured. Now after 2 months of integration, doing a roll flap just to give more thickness at this thin part of the central, the implant. And you can see it, we have some thickness of the soft tissue after a few weeks. And then we go prosthetically, scanning, we do our PMMA, temporaries, a 3-unit bridge, crown. And as Christian was saying, I'm one of those speakers that don't show the face. I just show, some teeth. Okay? Unfortunately, we should show the whole dental facial aspect of the case. That's how we started, that's how we ended. 5 years, 6 years, functioning, not the best aesthetic outcome. The last case, what about full arch rehabilitation or reconstruction? How do we manage full arch reconstructions, immediacy, and digitally, predictably? In cases where you want to immediately extract and immediately place and immediately load with a prefabricated temporary. You're not taking impressions. So this is the case. Look at it. Up here, this is the patient. Again, when it comes to full arch immediacy, unfortunately, again, I see a lot of clinicians, the first thing they do is they plan to reduce bone. The only thing they reduce bone is for it's easier to place your implants. But when you look at the architecture, yes, the hygiene is horrible. There is bone loss in the CT, which you'll see. Yes, there is. But these are sockets. There is some soft tissue architecture. I want to preserve this. And again, these teeth are very good to design the guide to be teeth supported for accuracy. Look at the lower and the upper. Immediacy, same day. So after scanning the patient, now we start planning. Scan, and then we plan. Plan where to place our implants, where we're going to extract, place our implants immediately according to the best position, the best centric occlusion to this patient in the upper and the lower, putting in mind that after you extract, we all know, even if you place bone inside these gaps that we're going to place, you will have remodeling. You will have soft tissue remodeling and bone remodeling. So on the design, on the planning, you have to put into consideration this remodeling because you are immediately going to full arch, you're going to place your temporaries without any impressions. The temporaries are going to be prefabricated, and that's when we use stackable guides. So designing where I'm going to extract, where the infections are, avoiding infections, placing implants, more palatal. This is all done on the software. Now you can see the stackable guides. We have 4 guides. When we print this, 4 guides. Initial guide, 2 supported guide, implant placement guide, restoration guide. These are the 4 guides. When we do this above one here, this is the initial guide where we have stacked the teeth guide on top of it. It clips on top of it. Then we place it on the teeth so it's perfectly accurate, it's supported. And now we use our anchor pins to stabilize the initial guide. And from there, now I remove my teeth or tooth supported guide. This initial guide that you see with the anchor fixation pins is going to be there until you deliver the final restoration. Now, it's very challenging through these guides to atraumatically extract the teeth, clean any infection inside. So we did this after extraction. We clean, degranulate, no flap, nothing. Now we place our implant guide on top of the initial guide. Everything is stacked on top of each other. According to the plan from the software, the diameter, the length, everything to get the good primary stability. Now we start drilling, placing our implants. This is just to show you a small video of the stackable guides where we fix with the anchor pins after placing the teeth-supported guide on the initial guide, as you can see. Once these pins are fixed, they don't move, nothing moves, because any movement in full arch reconstruction's immediacy, you're going to immediately place your temporary, which is prefabricated beforehand. Any movement will dictate what's coming afterwards. So now, after placing the implants, drilling, placing implants, you've seen even from the drills, you can collect a lot of autogenous bone that you can use to place inside the gap after placing the implants itself. As you can see, look at the amount of autogenous bone that you collect while drilling. Then placement of the implant through the guide itself, again, to position it exactly, because remember, we've placed these implants through the guide, we've planned everything to the extent we know exactly the height of the cuff of the multi-unit abutments that we're going to be placing. Are we placing straight multi-unit abutments? Are we placing angled multi-unit abutments? What height are we having in these multi-unit abutments? Putting in mind that we already planned that there will be at least 1 millimeter, minimum 1 millimeter of remodeling of hard and soft tissue. So now I know the height exactly. Again, all this will dictate the end product. Once these are placed, the multi-unit abutments are placed in hand just to see everything. And now we can pick up. We place our plastic or titanium sleeves. Here I use titanium sleeves, in which I pick up my restoration. Now I place my restoration guide stacked on top of the initial guide, which has access holes exactly where these titanium sleeves are, and I pick them up. Everything is stackable, everything depends on everything, but it depends on the proper planning from the beginning. Here's after immediately placing. Screw retain the full arch. Lower, the same thing. And we all know, whoever's doing these big cases, placing the guides, drilling and placing implants, it will take us like an hour and a half with the extraction. Restoring takes 3 hours at least. So the lower, the same thing. Still, I have like 4 teeth, which will be too supported. You never remove, because again, I see a lot of doctors, what they do first, they extract this and then they scan and then they get soft tissue support, which is not as accurate because it moves. Any movement in sideways, tilting, it won't be proper in the occlusion. Same thing, look at the stackable guides, the initial 3D printed models with the teeth on, after extraction, before we extract. And all the stackable guides, the same concept. So the first upper, because I had some soft tissue architecture, it's an FP1 prosthesis. The lower here, I had to do some bone reduction between the implants, so I'm able to place my multi-units and my restoration. And I had already bone resorption, so it's just an FP3. Here it is, picking up the titanium sleeves the same way. So this is an FP3, polishing, smoothing, everything, and now I just screw retain, and this is the patient immediately. It takes like 5 hours, this full procedure. Not to place the implant, but the restoration is the problem. So, conclusion, I know I'm finishing. Conclusion, we need to integrate all the tools available, surgically, prosthetically, every tool you can, and technique-wise, biologics that you're going to be using to enhance your implant treatment aesthetically and for a long-term success. And with this, I would like to thank you for the kind invitation and for being here till now. Thank you.
Thank you very much, Bassam. It was a wonderful lecture. Really, really enjoyed it. And I think one of the things, if you believe in surgical guides, is the stackable guides. It's a game changer. Wonderful tips. And please accept a certificate of appreciation. Thank you.